final things we're going to do before we wrap up, it's actually going to be a short session, discuss the difference between pulmonary and systemic circulation. Actually, we'll do this and then we'll do the non-respiratory functions of the lung. Does anyone want to just have a go at just, again, I'm all about categories. Like imagine you haven't studied this in ages, and if you could just remember anatomical, blood volume, pressure, vascular, pulmonary vascular resistance, and response to low PO2, for me, these were the categories that would allow me to fit just lots of facts to get as many marks as possible. So take a few minutes and just fill that in.
So the pulmonary circulation is a low pressure, low resistance circulation. So it has very thin wall with minimal smooth muscle and it's distensible. As opposed to systemic, which is high pressure, high resistance. So it's thick walled, abundant smooth muscles, and is not as distensible. There is then the blood volume. There's about sort of 9% in the pulmonary circulation and about 84% in the systemic circulation.
Say the percentages again, sorry.
Blood volume, so about 9% in the pulmonary circulation and about 84% in the systemic circulation.
Sounds good.
With the remaining in the heart. And then the next one is pressure. So like I said before, pulmonary is low pressure, so an average about 25/8 with a map of about 15. And the systemic will be 120/80 with a map of about 90. So the pressure difference between the inlet and outlet is higher on the systemic circulation, about 100 millimeters of mercury, whereas on the pulmonary side, it's a low resistance, about 10 millimeters of mercury. Response to low PO2, so pulmonary will be the hypoxic pulmonary vasoconstriction, whereas in the systemic, it would dilate instead to increase oxygen nutrient deliveries to the hypoxemic tissues.
Yeah, sounds good. So I've just, hopefully that framework helped. You got lots of facts down, and I might have some different facts, but I don't imagine this is something you need to memorize absolutely verbatim. So yeah, anatomical, receives mixed venous blood from the whole cardiac output, filter of blood surrounded by air-filled alveoli. Capillaries form a dense sheet around the alveoli, thin blood gas barrier. Pulmonary arteries are thin-walled, like you mentioned, less smooth muscle. There's 10% of the total blood volume, roughly. 25/8 is the pressure, and I've just got some extra pressures and pressure differential, but you mentioned all of these. Blood flow is altered due to hydrostatic pressures related to gravity. Base versus the apex. Pulmonary vascular resistance low, and I've got here 1.7 millimeters mercury per liter per minute. And it's altered by lung volume. And the response, exactly what you mentioned, hypoxic pulmonary vasoconstriction redirects blood flow from poorly ventilated areas. Then we've got the systemic. So, distribute the cardiac output to the whole body and multiple organs. It's not a filter. It's surrounded by tissues enveloped in fluid. Capillaries are less dense and further from tissue walls, so there's a greater diffusion distance, which makes sense. And the arteries are thick walled and there's more smooth muscle. Blood volume is about 85% of the total volume. The pressures are, as you mentioned, 120/80. Ventricular pressures, atrial pressures, AV difference is quite substantial, and capillary pressure is 30/10, and overcomes hydrostatic pressure to distribute blood flow according to demand, which is different obviously to the lungs. Systemic vascular resistance is high, like you mentioned, and this comes down to about 16.3 millimeters mercury per liter per minute. It's not altered by lung volume, obviously. And then responsive PO2 vasodilates, as you mentioned, increases blood flow and oxygen supply to tissues. Yeah, great. And look, I was trying to find a good diagram. I forgot where I found this on Google somewhere, but this I found was reasonably good, just as a way to quickly diagrammatically represent what's going on. What's happening here, Catherine? What's this graph demonstrating?
Is a graph or a diagram showing the changes in the compression of the alveolar vessels based on, I'm assuming, like where you are at different lung volumes. So if you've got high pressures in your alveolus, for example, at high lung volumes, is that right? You get compression of your alveolar vessels, but then at those low lung volumes, where you've got less pressure in the alveolus, you've got actually compression of your extra-alveolar vessels.
Ooh, is it compression of your extra-alveolar vessels, or something else? So just go through that again. As your alveolus...
It's more that not being held open by the surrounding elastic lung tissue.
I've got a different term. So the alveolus, as it increases in lung volume, compresses your alveolar vessels, exactly right, but then provides radial traction. So it's an active process, radial traction on those extra alveolar vessels. So good, we're talking about pulmonary vascular resistance here. So let's get this again. Take 3 minutes, discuss pulmonary vascular resistance and the control of pulmonary vascular tone. So what's the normal value for pulmonary vascular resistance? Outline the physiological factors that influence it. Take 3 minutes, draw an outline, get as many facts down as you can. And I'll ask at the end of that. Actually, I'll ask you, Catherine, at the end of that.
I have to admit, I don't have a great structure for this, but I'll give it a go.
That's going to be perfect. If you have no great structure, what's your default structure?
So I guess the default structure is definition, normal values, and a graph.
Sounds good. Let's go with that.
Pulmonary vascular resistance is like your resistance to flow across your pulmonary circulation. And you could describe it using Ohm's law. So it's equal to change in pressure resistance is equal to change in pressure divided by the flow. And the physiological and the normal value is 1 to 2 Wood units, which is liters per minute per millimeter of mercury. Physiological factors that influence it.
I think it's millimeters mercury per litre per minute.
Oh yeah, yes, I put them around the wrong way.
Yeah. And you know that because pressure at the top overflow.
And the physiological things that influence is primarily lung volume.
Actually, before we get to that, which graphs did you draw, by the way, if any?
I don't know if I can.
Yep, great.
I drew this one.
Talk to me about that one.
Which is lung volume versus pulmonary vascular resistance. Showing that the pulmonary vascular resistance is lowest at FRC.
Perfect, and I feel like you don't have to draw much more than that. You've got some labeled axes and the point of FRC that explains everything. What would a graph look like of arterial pressure and resistance? So pressure on the x-axis and resistance on the y-axis. So as arterial pressure increases, what happens to your pulmonary vascular resistance?
You said that all the time, Lydia.
Yeah, if you were to draw a graph of arterial pressure with pressure on the x-axis and then pulmonary vascular resistance on the y-axis, what does that graph look like?
So you'd see a decrease in PVR.
Oh, I've got the wrong way.
Oh, yeah, sure. Yeah, and I think Meg volunteered the answer. Yeah, and you're right, Meg. But Catherine, show me your graph just as you had it, but incorrectly.
I've got it around the wrong way. I went pressure going up as...
Yeah, exactly. And if you strictly went through Ohm's law, you're not wrong, right? Except again,
yes,
we're trying to model complex things with multiple variables based on electrical physics, right? and it just doesn't work that way. But that's good. So I'll just quickly show. So intro graph, formula, normal values, passive control, and then I've just got here categories: passive control, active control. Let's get to what are your factors that affected it, Catherine?
So I suppose is passive control talking about like your lung volumes and that point that you talked about before, where at high lung volumes you get compression of your alveolar vessels, but that's wide open extra alveolar vessels, and then at low lung volumes you lose that radial traction on your extra alveolar vessels, so they collapse down, which contributes to your increased pulmonary vascular resistance at low lung volumes.
And again, if you were to list me just the factors, so that if you're in an exam and what affects you, you go passive control, active control, passive control equals this, active control equals this, how would you, what else you got without going into detail just yet?
So passive control is lung volumes and I guess pressure, like your driving pressure. Maybe.
I've just got the FRC as part of this, but cardiac output, blood gravity. FRC is the lung volume factor. Blood factors because it's kind of the Hagen-Purcell equation with. But anyway, let's get into that later. Active control.
And then active control is like your hypoxic pulmonary vasoconstriction, which is augmented by CO2 and hydrogen ion concentration, so high CO2, low pH.
Anything else? There's things that you could get,
like metabolic and myogenic. I suppose it's not really so much a thing of the pulmonary system though. I'm not sure.
No, all good. So active control I've got here for, so there's the first graph just for everyone. As you increase your pressure, the pulmonary vascular resistance actually decreases. Active control, CO2, oxygen, sympathetic nervous system, parasympathetic nervous system, humoral mechanisms, and then there's always drugs as well. Like, you know, most of your vasopressive drugs will actually increase your vascular tone in your pulmonary system as well, unfortunately. Meg, what do you reckon? What's critical opening pressure?
I don't know if I have a punchy way of saying this, but I think it's the pressure that's required for distension and recruitment of, just pressure that's required for recruitment. So it's the pressure that's required to open a capillary that's collapsed downstream.
Yeah, perfect. The pressure at which lung flow occurs in a collapsed, flow occurs in a collapsed lung, which is pretty much what you said. You've got these unrecruited or collapsed vessels, and that's the critical opening pressure, several centimeters above the downstream pressure. What is the difference between recruitment and distension, Meg?
So recruitment is opening a previously collapsed vessel, and distension is just increasing the radius of an already recruited vessel.
Perfect. That's exactly right. So we have here distension increases the caliber of vessels, whereas recruitment is opening of previously closed vessels. We've got a few diagrammatic representations of that. Just to go through a bit more detail, I mentioned passive control and active control. So cardiac output, lung volumes, or FRC, being the point of lowest pulmonary vascular resistance, blood factors, and gravity. So cardiac output as cardiac output increases, this decreases pulmonary vascular resistance due to distension and recruitment of capillaries. So then you can show that graph, which we showed of the decreasing resistance with increasing pressure. The lung volumes is the graph of FRC being the point of lowest pulmonary vascular resistance, and it's because of the balance between those alveolar and extra-alveolar vessels and the radial traction on the extra-alveolar vessels, as well as the compression of the alveolar vessels. So having that in a succinct way is very important. I've mentioned blood factors, where resistance, according to the Hagen-Purcell equation, resistance equals 8 viscosity times length over pi r to the power 4. So viscosity or hematocrit may increase your pulmonary vascular resistance as well. I've just put that because that, I can just plug it into that equation and briefly mention that. I don't think it's the biggest factor in most circumstances, so I'm not going to put much weight on that. Gravity, so Westons of the lung decrease pulmonary vascular resistance down the lung. With active control, I've just put that active because it's kind of the chemicals as they affect the smooth muscle. So CO2 causes vasoconstriction, oxygen causes hypoxic. Decrease oxygen. So increase CO2 causes vasoconstriction. Decrease CO2 causes hypoxic pulmonary vasoconstriction. And then your sympathetic nervous system, alpha-1 receptors. So noradrenaline and adrenaline act on alpha-1 and beta-2, so alpha-1 would increase your pulmonary vascular resistance. Adrenaline causing beta-2 stimulation, so therefore your higher cardiac output would decrease your pulmonary vascular resistance. And then I've put the fact that your parasympathetic nervous system has its effects, and the humoral nervous system has its effects as well. See if I can actually put some of this in the chat. I'm sure you've got notes with all of this stuff anyway.
Lahiri, can I ask you to put up your graph comparing arterial and venous pressure on pulmonary vascular resistance?
Sure can.
I find this quite a difficult concept to wrap my head around, especially because we often verbally describe it as increasing flow causes a decrease in pulmonary vascular resistance through recruitment and distension, and yet we don't graph flow, we graph pressure. I kind of can wrap my head around the arterial curve on the upper limit, that if we increase the pulmonary artery pressure, you're going to cause that distension and it's going to help things flow through. But with the venous pressure curve, I would have thought that inevitably increasing venous pressure is then therefore decreasing our driving pressure, and overall flow would be less, and flow being less usually means resistance is more.
I agree. And so I'm going to stop you there.
Good way to explain that.
So again, because the human body is complex, we're putting formulas to try and describe this, and these formulas are just really inadequate for moment-to-moment changes with everything that's going on. So the question I put to you is, the graphs are true because they're usually data points that have been measured. So how would that be true? How would it be true that increasing pressure, even if there's decreased flow, would still decrease pulmonary vascular resistance?
So I guess by increasing pulmonary venous pressure, or so that atrial pressure or pulmonary capillary wedge pressure, you're almost creating a build-up or a reservoir of blood behind us, because as that's the the resistance point, which then just distends the vessels proximal to that high pressure point. So I guess you've got decreased resistance, but you've also got decreased pressure gradient causing the decreased flow. So
yeah,
while your pulmonary vascular resistance is decreased, you would accept that flow would decrease as well.
Yeah. So I'm just going to explain that back to you. If I've got increased venous pressure, on one hand, if I look at resistance equals change in pressure over flow, on one hand I've got decreased flow, which potentially is a problem, but on the other hand I've got decreased driving pressure because there's less of a difference between the arterial and venous side, and then I've also got recruitment and distension now as well. So I've got all these things happening at any point in time. So that's the only way I'd explain this to, give the answer that this graph is actually true. And that I feel like that's all reasonable. I think it's pretty easy to explain. But yeah, definitely not being stuck on the fact that this is an equation that only one variable ever changes at one time, which is just not true.
Thank you very much.
No worries. So we've gone through that. Yeah, these are really good questions. I think this is the stuff that ends up kind of being discussed in the Viva as well. Like, it's kind of the subtleties of each of these graphs. We're not getting into too much, we're not, it's a specific kind of detail that we're talking about, which is, I think, really useful. Everyone have a go at drawing the West zones, answering the questions, how does it distribute? Just draw the West zones and then we'll answer these questions together. So yeah, take a couple of minutes, draw West zones, and the equations of P little a, P V, and P alveolus. And then for the West zone 4, obviously there's another factor.
I haven't labelled it yet, but it should say West zone 1 at the top, West zone 2 here in the middle, and then 3 for the bottom one.
Yeah, nice.
So I've got the, where is it? The arterial side coming in here, the high pressure in the alveolus is greater than that, and so there's essentially no flow across into the venous side. I've got here West zone 2, which is probably the majority of the lung. There's variable alveolar pressure, and then there's variable flow from artery to vein, and so this is the kind of the Starling resistor concept.
Yep, sounds good. And what is flow determined? What is flow, George, determined by in West Zone 2?
So they're determined by the alveolar pressure.
More specifically, alveolar pressure and something difference.
The alveolar arterial pressure difference.
Yeah, I say arterial alveolar pressure difference, obviously because arterial is larger, but absolutely.
Yeah.
And why does flow increase in going down West Zone 2?
Because the amount of, so with gravity, the hydrostatic pressure within individual alveolar kind of arterial supply is going to be higher just from the columnar fluid.
Good. So
effect.
Your answer is right, and the quick way to say that is because arterial pressure increases, and due to gravity. So that's right. If it's arterial alveolar pressure difference, alveolar pressure stays the same. Arterial pressure increases due to gravity, as you go down, therefore your flow increases. That's good. Keep going. What's West Zone 3?
Yeah, West Zone 3 is essentially just a quote-unquote normal situation where the arterial pressure is greater than venous, which are both greater than the alveolar pressure. And so flow is determined by the AV difference in pressure.
And what happens there? Does that increase down that zone or decrease or stay the same?
It should stay the same, essentially.
It increases, actually.
Sorry?
It increases as you go down West Zone 3. And why would it increase then?
Well, I would have thought the hydrostatic pressure effect would be the same amount of increase between the arterial and the venous.
So something else is happening. So recruitment and distension is happening.
Okay, yeah, that's true.
Yeah, good. How about the final one, West Zone 4?
This is one I always struggle to remember, so I was trying to think of how to draw that.
No, that's right. There's only one other factor at play here, and in sick lungs. What is the other? Can you remember the other variable here?
So if you had collapse of the alveoli, no.
They talk about interstitial pressure now being the variable. So PA greater than P interstitial, greater than the other two. So if in pathological lungs, this causes decreased flow as the interstitial pressure increases for whatever reason. Cool. And I'm just gonna. And this is what you're showing me. And so I'm pretty sure this is West as well, where, as you mentioned, there's no flow in West Zone 1. You see increasing flow in West Zone 2, which is governed by the arterial alveolar difference. And then you get the normal one, the normal flow characteristics due to the PA-PV difference. And then it increases as you progress down due to recruitment and distension. And finally, if you're in pathological lungs, you have PA and P interstitial governing flow. And if you get increased interstitial pressures, this causes a decrease of blood flow. I like that graph because it kind of just demonstrates a lot of things in one go. Next person along, Luke, how does it distribute? We've said how it distributes. What happens in the supine lung?
When you transition from the erect position to the supine position, there's a reduction in the hydrostatic gradient between the dependent and non-dependent lung, and that's just because the distance between the anterior-posterior dimensions of the lung are less than the apical base in the erect position. Mm-hmm. So as a result, you would get a higher fraction of West Zone 2 and 3 and less of 1. Mm-hmm. West Zone probably 3 would increase the most, then West Zone 2 would increase a little bit, and West Zone 1 should completely disappear.
Okay, sounds good. And what happens in exercise?
With exercise, there's an increase in cardiac output, which can increase up to 25 litres per minute. Mm-hmm. This results in pulmonary vascular recruitment and distension, as we've previously discussed. Mm-hmm. And this would also reduce West Zone 1, would also increase West Zone 2, and most significantly increase West Zone 3.
Sounds good. Did you say it would increase West Zone 1?
No, it will definitely not increase.
No, good. He would pretty much take that away. We've drawn that. This is alveolar dead space in Zone 1, as we mentioned. We've already talked about West Zone 2 and West Zone 3, and then West Zone 4. So West Zone 4 occurs in low lung volumes. Narrow extraalveolar vessels means increased resistance to flow. Good. Look, the final topic before we head off then, outline the non-ventilatory functions of the lung. Well, I shouldn't have put that there. I just want everyone to have a go, take a minute and just write down as many of those things as they can. And if they've got a good way of remembering it, again, it's a list of a bunch of stuff. Maybe if you've got a good mnemonic or just a good way of categorizing the groups of things, please share with us.
I'm happy to have a partner here, but
I
don't have a pre-known structure. So, the 4 big points that I put down were the effects on pulmonary vascular resistance as a contribution to whole circulatory blood flow. its function as a venous return mechanical pump, its function as an immune barrier between the environment and the body, and its impacts on drugs and hormones through both uptake and metabolism.
Yeah, sounds good. What do I have here? Blood reservoir, blood filtration, metabolic function, surfactant synthesis. So I feel like there's a few metabolism synthesis things. So metabolic function, synthesis of surfactant, protein, prostaglandins, carbohydrate metabolism. Oh, sorry, and then there's the metabolism things, carbohydrate metabolism, removal of proteases, and then heat regulation. It's a protective function and drugs as well. And if I was just to go through these, for example, look, Mason, how much volume of blood is in the lungs in an adult?
In total volume.
Yeah.
So I'm just remembering back from Mish saying before, so it was about 8 or 9%, so 10% for simplicity, and with a total blood volume of 5 litres, so it's going to be around about 500 mils.
Fantastic. So increased pulmonary pressure equals increased volume of blood in the lungs. The lung has remarkable ability to decrease its PVR. That's all good, which we've already talked about. These same mechanisms allow the lung to increase its blood volume with relatively small rises in pulmonary artery pressure, venous pressure. This occurs, for example, when a subject lies down after standing. Blood then drains from the legs into the lung. Great. How about blood filtration? Let's say what level of particle will it filter out?
I would imagine anything larger than a red blood cell. So
that's exactly
greater
right.
than
10 micrometers.
Oh God, how many micrometers? 3?
10 micrometers.
Yeah. So anything greater than 10 micrometers would likely be filtered, would not pass through capillaries and therefore be filtered. So this would include things like small blood clots forming within the venous circulation, which are occurring all the time, as well as any particulate matter from injected drugs.
This might be an obvious question. Why is that important? Why do we want to filter stuff from the lungs? But essentially, that's just lots of microemboli causing blockage. Why is that important? Why is that good even?
Yes, I'd rather have a small PE than a small stroke.
Yeah, sounds good. The lung has a lot of reserve, a couple of small emboli blocking up a couple of bits that will then, the body will try to get rid of that. There's normal mechanisms of clot breakdown, but yeah, that goes to the brain. That's less forgiving. Fantastic. So yeah, this prevents these clots or any kind of particles greater than the size of a red blood cell or 10 micrometers from reaching the brain and other vital organs. So gas and fat emboli and thrombi are quickly broken down in the lung. So the lung is actually a rich source of heparin, a plasmin activator, and thromboplastin, and these can all affect that as well. So metabolic function, the lung is the only organ except the heart that receives the whole circulation, is therefore uniquely suited to modifying bloodborne substances, and so specifically metabolic vasoactive substances. So there's just this huge list. There's angiotensin, converting enzyme, bradykinin, serotonin breakdown, prostaglandins, as well as noradrenaline. So up to 30% of noradrenaline is removed. Then surfactant synthesis, that's pretty self-explanatory. We've gone through that in previous tutes. Protein and prostaglandin synthesis. So it's a major site of synthesis and metabolism of arachidonic acid metabolites. And then carbohydrate metabolism. So in more detail, it's the mucopolysaccharides of the bronchial mucus. Removal of proteases, that's the alpha-1 antitrypsin in plasma, protects the lung from proteases. And then heat regulation. So mainly there's the upper respiratory tract, but warms and humidifies inspired gas. And the daily insensible water loss is about 400 mils. What's the protective function, Mason?
So given that the lung has a large total surface area, so between 100 to 150 meters squared, it's a large potential source of entry for pathogens to enter into the body. So there are multiple functions of the respiratory system to limit this. So these include simple filtration with nasal hairs and cilia in the upper airway. It also includes production of mucus to trap small pathogens, the mucociliary escalator to beat that pathogen trapped in mucus up towards the upper airway to be coughed out. It also would include pulmonary alveolar macrophages down at the alveolar level for an innate immune response. And I I'm trying to remember if the lung has lymphatics.
It's got IgA in the bronchial mucus.
Yeah.
That's good, and also sneeze and cough reflex. But you're right, and you called it a mucociliary escalator. I've got elevator, but hey, an upgrade is always good. And yeah,
Yours is more steep, mine's a
exactly. Yeah. And then drugs. So drugs in terms of administration is another function. So nebulized sublingual adrenaline, excretion of volatiles, first pass effects of many drugs as well. And then phonation. I've got here phonation, buoyancy, and also acid base. There's a whole bunch of things. And I can imagine them asking a question where you can just kind of rattle off a few of these, and then they can get into a bit more detail about each of them.
I love buoyancy. It's a good one.
Yeah, that's very good. Yeah, so that's pretty much it for us. For respiratory, I imagine most of you guys are sitting your exams in August. Fun.
I think about half of us. So Luke, Catherine, Davis, and I.
Okay, cool.
Actually, any of the other ones that I just haven't heard of, Brian or George? I don't know. No.
Yes. If you have any questions, feel free to email it. If I don't reply, just email me again. I'm really happy to be hassled. I live deadline to deadline these days, yeah. So don't worry about hassling. Just keep asking, and I'll definitely get back to you. And it does help me if you ask, because then I'll hopefully gets my talk sharper, and these kind of detailed questions hopefully get better and better as well. So yeah. Any questions before we end for the last respiratory session?
Thank you very much for the last 3 weeks over the last 5 weeks.
Yeah, that's right. It's a very special kind of 3 weeks. Thanks, guys. All the best, and yeah, hope lockdown ends in 7 days.
Wow. Enjoy West.
Enjoy fair.
Thanks.
I am. I feel almost guilty, but not. See you guys. Bye.